Hello, my name is Dr. Jeff Zobel. I'm a pediatric clinical pharmacist at a children's hospital in Arizona and been working in the cystic fibrosis space since 2005. And so I've seen a lot of change in cystic fibrosis. And the title of this webinar is "The Only Constant with Cystic Fibrosis is Change in the Era of Highly Effective Modulators." I'm also a clinical support liaison for MVW Nutritionals, who provides cystic fibrosis vitamins and probiotics for CF patients and their families. The objectives of this presentation, this webinar, is to provide education for families and caregivers regarding cystic fibrosis. We're going to look at basic pathophysiology, basically what cystic fibrosis is and the organs affected, but also review the effects of highly effective modulators and what they have on CF, looking at the new registry information that was published by the Cystic Fibrosis Foundation at the end of 2023. When we look at cystic fibrosis itself and the demographics, the information that has recently been published, we can see that now there are over 100,000 cystic fibrosis patients, both pediatric and adult, worldwide, with 40,000 of them being in the United States alone. In 2022, there were almost 750 new diagnoses, mostly through newborn screen across the United States. The median age of survival has increased significantly since 2016, when it was 43. Now it is up to 56, which is a large jump since when I started in cystic fibrosis in 2005 as a pharmacy resident and a pharmacy student, when it was 28 years of age. So now we've seen it more than double in my professional career in cystic fibrosis. The body mass index and lung function numbers have increased significantly to the point where now the percentage of adult patients with normal lung function is over 90%. There are more adult patients now than there ever have been as a percentage in the entire population, where now almost 60% of all cystic fibrosis patients are over the age of 18, which is a massive improvement that we've seen over the years, where now adult centers are having to take care of these patients, and this number will continue to increase as the total population increases, but also the percentages they live longer and have healthier lives with the advent of highly effective modulator therapy. The number of pregnancies in cystic fibrosis patients has also more than doubled since 2019, when elexacaftor, tezacaftor, ivacaftor was FDA approved in 2019, where now almost 600 pregnancies in CF patients have been reported in the registry information. So what is cystic fibrosis? For those who are aware of it and see it every day, this is information you probably know. But for those who don't know, we're going to talk about a little bit what cystic fibrosis is and use an analogy of a lock and a key. So cystic fibrosis is a genetic progressive disease that affects the organs of the body. Anywhere there was a tube that can go to the outside, like the lungs, the pancreas, the liver, these are examples of organs that are affected. There are several different mutations. There's over 1,700 different disease-causing mutations that have been identified in cystic fibrosis that can lead to it. But these mutations are classified into 6 different classes 1 through 6. And those mutations in the CF gene, which code for the cystic fibrosis transmembrane conductance regulator, or CFTR, can lead to a non-functional CF protein channel. If you have a class 1 or 2 mutation, and these examples, if a class 1 would be an X mutation, like G542X, for example. Or if you have a class 2 mutation where you have F508del, which is the most common cystic fibrosis mutation, and almost 90% of patients have at least one copy of F508del. This is a class 2 mutation. When these patients have this, they have no channel at all. So think of it as a lock and a key. You have no lock and key at all. With an X mutation or the F508del, there's no lock and key to move any chloride ions at all in the cell membrane. If you have a class 3 through 5, this is where the channel just doesn't work right. Consider like a rusted lock. So a class 3 mutation would be G551D being the most common. Class 4, 5, and 6 are less common mutations, and they're not as severe. So someone with a class 6 mutation may be pancreatic deficient, for example, but those are less common mutations in the CF population. But still, they have a channel, it's just not working right, and they still have cystic fibrosis. If you do not have cystic fibrosis, these are patients who are carriers or people who do not have any mutations. Your DNA is healthy, so it produces perfect RNA, which then codes for a pristine lock you could buy at a hardware store, which is a CFTR channel, and that CFTR moves chloride ions across the membrane of the cells, which then attracts water, and that water attraction can lead to the normal thin mucus that you will see flowing through all the organs of the body. If you have cystic fibrosis, something is going on with the DNA and the RNA. Something is flawed. And so you have either no chloride, no CFTR channel function at all, or you have the rusted lock where the CFTR is not working appropriately. Something is going on with the chloride ions. Either there's no chloride ions movement at all, or there's less chloride ion movement. There is either no water attraction or less water attraction. But regardless of what happens, it's still, instead of the thin mucus that we have in the body, we have a thick mucus that can affect all the organs of the body. So think of it like a swamp, and you have swamp friends like Shrek that could live in the swamp, and it clogs different organs of the body, leading to issues. And so you have sinus issues, can lead to nasal polyps in the sinuses for patients and in the nasal cavity. Salty sweat. So this is why you do a sweat chloride test, because the chloride pushes out, it doesn't get reabsorbed into the chloride, into the cells. And so that's why you have elevated sweat chloride. They get acid reflux, so they could have, their stomach more increased acid production. They have a thing called pancreatic insufficiency. So they have their pancreas is not working correctly, not releasing the enzymes. So you can have vitamin deficiencies, fat malabsorption, and constipation. You can have hepatobiliary disease, which is the liver, which can affect the bile, which is a solution that moves through the bile. It can be clogged and sludging, and you can have problems with that. If you have other issues, it doesn't happen to every patient, but we can talk about this. That it's called CF-related diabetes. That can happen in the cystic fibrosis population. And then there's mucus-clogged airways and lungs, leading to lung inflammation, frequent bacterial infections, and can have lots of issues with that. And also men are infertile because of the vas deferens being affected. So as a pharmacist, we focus on the medications. That is what I have done my entire career, looking at medications to help our cystic fibrosis population. And so it's divided up into 3 different categories based on the organ systems. So the first would be the gastrointestinal tract. And so this is where we have pancreatic enzymes. We have the CF-specific vitamins. We can have medications that can help the liver, help with constipation. So that is what we're doing, and help medications with acid reflux. So those are the medications we have for the gastrointestinal tract. For the endocrine system, which is the pancreas. The pancreas has two different functions. There's the exocrine portion, which is what releases the pancreatic enzymes for digestion. There's also the endocrine portion, which releases insulin. And so patients who have cystic fibrosis are at risk of cystic fibrosis related diabetes. It roughly about 30% of about 20% of all CF patients nationwide have been diagnosed with CF-related diabetes, but it usually happens over the age of 10. So we see more in the adult population. Roughly 30% of all CF adults have been diagnosed with CF-related diabetes, where in the pediatric population is not as much. We don't start screening for it until age of 10. And so that is why you don't usually see it in the pediatric population. You usually see it more in the adult population. But the treatment for CF-related diabetes is insulin. And there are guidelines that have been published and you can work with endocrinology and your CF team to help with the treatment of CF-related diabetes. The last organ system would be the lungs. And so we would hope the goal would be pristine, healthy lungs for all patients. That is the overall goal of CF providers and CF teams. And we have medications that help with this, that range from bronchodilators, so albuterol, that open up the airways. We have medications called mucolytics, hypertonic saline, Dornase alpha, inhaled mannitol that can break up the mucus and thin it out to allow them to breathe easier. We have inhaled antibiotics, which can help with the infections. So inhaled tobramycin, inhaled aztreonam. We also have anti-inflammatory medications such as azithromycin. All of these are used to help symptom-based management to help our patients be better and improve their lung function. We do, however, have another medication that can help the entire system, all the organ systems. It affects the entire body. And this is the CFTR modulators. And we have 4 of them on the U.S. market. There's another one that I'll talk about that's going to be released hopefully in mid-2024 that is new that we can talk about. But all of them have ivacaftor in them. And ivacaftor is a medication. It's the original modulator that came out in 2012 that helps target specific mutations in the class 3 through 6 categories. But we have the other medications that have been released. First, we have Lumacaftor, ivacaftor, which is FDA approved down to age 1. That is for the F508del homozygote population, so they have to have 2 copies of the F508del. Ivacaftor is FDA approved down to 1 month of age, so we have patients that can start it almost upon diagnosis. They can start on a medication. Tezacaftor, ivacaftor is FDA approved down to age 6, and then we have the highly effective modulator that's considered, along with ivacaftor, elexacaftor, tezacaftor, ivacaftor. And that was FDA approved for ages 12 and above in 2019 and has now down to age 2 as of last year. So we're seeing significant reduction in ages of these advancements, but also the things that have happened since 2019 in this new era of highly effective modulators. And what we're going to kind of go through is the remaining slides of talking about what we're seeing from the CF information and what you can take back to your teams and ask questions. And we're not giving any clinical information about what to do. We're just present the information in this new era of what is actually happening. And so this is a graph from the most recent register report about what was happened since 2019 or since 2014 when we only had ivacaftor. As you can see, now since 2019, the change and how many patients are on the green section of the bar graph is elexacaftor, tezacaftor, ivacaftor. And this only includes up to 2021. So this doesn't even include the new patient populations that can get it in the 6 to 11 and 2 and above, which have just been FDA approved just recently. But this shows the percentage of patients who are on CFTR modulators by group, and the largest being elexacaftor, tezacaftor, ivacaftor, because it's FDA approved for multiple mutations. You only have to have one copy of the eligible mutations that are there, and one of them being F508del. So almost 20,000 CF patients are on, as of 2021 registry data, are on a highly effective modulator. And that number is higher now because it just delayed from the reporting of the CF in the CF database. But since now we have patients all the way down to age 2 are on it, we have a lot more patients on CFTR modulator than we did before. So when we look at the effects of highly effective modulator therapy on the CF population, we're going to start first with nutrition and then go through what we see with CFRD and in the pulmonary effects. And so we're going to go through each of those sections. And so the first would be nutritional effects. So this is from the most recent CF registry data in 2023 that was at the end of 2023 when it was published. This is 2022 data. We look at the percentages of patients and their BMI percentile distribution in the pediatric population as well as in the adult population. What we're seeing is a trend towards patients in different categories. In the light blue and the green, patients are able to absorb much better than they were before. And there's some effect on the nutrition, and it's happening. We're seeing this across the board, but this is something from the CF Foundation. It's helping patients get to BMI goals much better than they ever were before, and we're seeing positive effects with that. And so when you look at the information, this is from the registry report, but also from studies that have been published since 2019 forward, one with ivacaftor, but also elexacaftor, tezacaftor, ivacaftor, we're seeing now that 65% of CF adults are now at the CF Foundation BMI goal. And 13% of those patients are considered in the obese category of the CF Foundation registry report. The percentage of patients have more than doubled who are overweight or obese since 2001, which is something that we dietitians are interested in and looking at. So this is something you can talk to about your dietitian team about. But there are several case reports of CF patients who've been converted from pancreatic insufficiency, which is PI, to pancreatic sufficiency, meaning their pancreatic enzymes, which is the test called fecal elastase test, is showing that it's a regeneration of the pancreas, and the patients are producing fecal elastase at a normal level, meaning they may not need enzymes anymore or have a reduced dose of enzymes. If this is something that you're seeing, talk to your team about it, because there is reports of it. Most recently, just a couple weeks ago, there was a report of patients, pediatric population, developing pancreatic sufficiency, being on elexacaftor, tezacaftor, ivacaftor therapy. There's also studies showing a decline in enzyme use, which is PERT, pancreatic enzyme replacement therapy, with ivacaftor. So patients who are on ivacaftor are showing they don't need as many enzymes. There's a survey that was just published by CF patients and providers showing decreasing acid suppression therapy, which would be like a proton pump inhibitor such as omeprazole or famotidine, and also decreasing doses of enzymes since highly effective modulator therapy. More studies are being done, but this is a positive trend that we are seeing in this population. in this event of highly effective modulator therapy. The second area of nutrition relates to the CF-specific vitamins. Since 2021, there have been multiple studies and case reports. A case report is something where they look at a patient and something interesting happens. But in these studies and in these case reports, we're seeing vitamin levels are increasing in patients who are on highly effective modulators. And we're also seeing toxicities, especially associated with vitamin A in patients taking CFTR, highly effective CFTR modulator therapy. So this is something we just want you to be aware of, that there are reports of vitamin D levels increasing, mainly D and A. Vitamin E doesn't seem to be increasing as much, but D and E, but D and A are the ones that we've seen increase the most. And A is the one that's associated with toxicities. And there are multiple case reports about toxicities associated with increased vitamin A levels. So that's something to talk to your team about and look at other options that there may be out there to help adjust this or help address this issue. After the nutritional effects, we can see the effects of highly effective modulators on CF-related diabetes. There are multiple case reports and studies that are showing promising information on the effect of highly effective modulator therapy on CF-related diabetes, but also some effects that are be considered metabolic syndrome, which could be associated with increased weight gain, but also effects on labs in the body, can lead to the macrovascular effects such as heart disease that can be detrimental in patients. And so that's why this is something just to look at. And so when you look at the positive effects of CF-related diabetes, we are seeing reports of lowered hemoglobin A1Cs, which is a measure of diabetes control. We're seeing positive effects on blood glucose management, especially measured by continuous glucose monitors, so that you can monitor the patient. We're seeing decreased insulin doses in patients who have been diagnosed with CF-related diabetes and are being treated. So those are the positive effects that we are seeing. One of the effects that we are seeing that relate to metabolic syndrome is increased fat mass in patients, but also effects on cholesterol levels, like LDL cholesterol and total cholesterol. Those numbers are also increasing. And so this is where work with your team. Talk to your team about any, if you have CF-related diabetes, just talk to your endocrinologist. Work with them. That would be the best advice you can do to talk about these issues that may be happening. Some other positive things that we're seeing, the effects on pulmonary exacerbation. So pulmonary exacerbations, basically when you're admitted to the hospital for the treatment with IV antibiotics. And the most recent data report shows since 2019, you can see a large, significant decline in pulmonary exacerbations requiring IV antibiotics in our patients. COVID also happened during that time, but so there might be some confounding information here. But overall, when you see this, after COVID, it has not gone back to the same levels. Now, there is a fluctuation in all populations, so pediatric all the way through adult, but the main take-home point is that highly effective modulators have had a significant effect on patients being admitted to the hospital and needing IV antibiotics. The other thing that happened is effects on pulmonary medications. And so This is just some information from the registry report for the most common pulmonary medications: Dornice alpha, azithromycin, hypertonic saline, aztreonam, and inhaled tobramycin, both being inhaled antibiotics. Since 2019, there is a decline in the medication prescriptions in these patients. And we're not advocating any change. This is where you talk to your team about individualized approach. This is just reporting the information that we're seeing patients are not filling medications as frequently as they did before. But this is where working with your team to find out the appropriate management for you in your family. Just some information for you all regarding the new CFTR modulator that has been, it's in studies. The studies have been completed and being submitted for FDA approval in mid-2024. It's called the once daily Vanza Triple. That is the new name for it. It's vanzacaftor, tezacaftor, ivacaftor. It's a once daily combination, triple combination that was studied in comparison to elexacaftor, tezacaftor, ivacaftor in 3 studies. And this is directly from a report from the drug manufacturer. As you see, the 2 studies, the Skyline 102 and 103 trials, were in patients over age 12. And they looked at a comparison trial between once daily Vanza Triple and ETI. And they were able to see it as a primary endpoint, meaning the primary measure, what they were trying to figure out, was the change in lung function, or FEV1. And they found that they were equivalent. They were equal. Vanza Triple and ETI both improved lung function the same. Their secondary endpoint actually looked at a change in sweat chloride results. And in this one, they found that the Vanza Triple had a stronger effect at changing the sweat chloride than ETI. Then they also had a greater percentage of patients who had numbers less than 60, which is a number to see if they actually have cystic fibrosis, diagnostically or not by sweat chloride, and less than 30, which could be like carrier status. And they found that the patients, that Vanza Triple was better at a greater percentage of patients less than 30 and less than 60 versus ETI therapy. When they looked at safety, they had multiple different safety parameters they looked at. They showed to be well tolerated. Side effects were very minimal when you looked at the Vanza Triple. In the patients ages 6 to 11, so they did the Ridgeline 105 trial, their primary endpoint was safety, because that's what they do in these trials. Once they've done it in older population, the next step would be just to look at safety and as it tolerated in the younger population. It was shown to be well tolerated with very minimal side effects. The secondary endpoint also looked at a change in sweat chloride, and they found that, again, Vanza Triple was able to change the sweat chloride more than ETI, and 95% of the patients had a sweat chloride less than 60 and the majority less than 30. So this is very, very good information for everyone that it's coming. We have some new information with Vanza Triple, and this is where find out from your team. And you can learn from them exactly when it gets approved and what the process will be. But from the information we are receiving from the company, it'll be around mid-2024 for FDA approval. So the conclusions of this, hopefully you can see that modulator therapy may support a change in the supportive therapies. We don't exactly know. As a response, modular therapy can differ based on when you start it, your genetic mutations with your gene and other variables. So this is where everyone, you work together with your CF team. Everyone's response to a modulator may be different. That's where an individualized approach will be. but your care team is who you need to work with. Talk to them. Hopefully this is informative, but work with your care team to provide the best recommendations around any potential changes with fat-soluble vitamin intake and the formulations, the use of inhaled therapies such as hypertonic saline Dornis alpha and other inhaled antibiotics. Work with them as well as on the modulators. Work with your team. They can provide the recommendations for you because they have the information. Work with them, and based on this new emerging data and clinical status, that's who we need to work with and have that information, because your care team is the source of the information, and they do good work, and we're grateful for all the work that they do. So this is our contact information. We're distributing this via as a recording that will be available via YouTube channel for any individuals to view. There's other webinars that we do have that are available that we're doing for care teams, but you're welcome as parents and caregivers to also view those. It goes in a little more detail about the different areas, but hopefully this information was informative, that you can gain more information about it and working with your care team to work in this new era of highly effective modulators and hopefully live healthiest lives possible, and just like what the CF Foundation wanting CF to stand for Cure found. And so thank you. This is my contact information. You can email me if you have any questions, or reach out to me, myself or my colleague, Kevin Epps. This is our contact information, and we thank you for your time.